I'm Dr. Daniel Kantor, Neurology in Real Time, and I'm joined here by Dr. Gary Cutter, who is Professor of Biostatistics at University of Alabama, Birmingham, and also the immediate past president of the Consortium of MS Centers. You are involved with almost every single trial in multiple sclerosis. And a lot of people back home may have been involved in some trials where there's a lot of testing. And sometimes they have to come in and they do not only what's called the EDSS, or the Expanded Disability Status Scale, beforehand. They seem to do it twice before a study. They do it when they're first screened, and then they do it almost like at a baseline as well.
Yes.
Why is that necessary? Why 2 times before the study happens?
The EDSS is actually a difficult measure to perform, and there's variability.
Okay.
So we want to be variability in what you're classifying somebody. And because it's what we call an ordinal scale with 1, 1.5, 2, if you make a mistake in one of the characterizations of the individual, the strength or one of the other measures, you can put them in a different category.
Okay.
And if you're going to measure whether or not someone has progressed from there, you want a good baseline. You want to be sure that where they're starting is where they really are. And if they have progressed, it's not just measurement error. Now, there'll be some measurement error. That's one of the reasons we randomized. And we assume, when randomized, what we mean is we put people into groups without caring what treatment they get. Seems pretty unhealthy, but it isn't. What it does is it tries to equalize the two populations and follow them forward. So if there's some measurement error, it's okay because it's the same in both groups. And we're looking for the signal that overcomes that noise.
Now, I remember several years ago, there were some studies where this was important. There was a study of CombiRx where I think it was important. There was a study of one of the medications, alemtuzumab, that are important. Where has this been important, the differences that you may or may not see between your screening and your baseline?
Well, I'm not cynical, but I'm a realist. There's a phenomena that we call regression toward the mean.
Okay.
That is, if you get in and you have to qualify to get in, either you have to have a level on the EDSS that's below a certain mark, or you have to have a level that's above a certain mark. And in either of those cases, any measurement error that you might be measured arbitrarily lower than you should be, and you take those people in the study and you measure them again, you'll measure them more correctly the second time. So they go up.
Okay.
But you don't have, on average, for the whole population, the people who were high because they didn't qualify. So they're gone. So on average, the measure moves up for both groups. And if you look at the trial results, you'll see when you do time to, say, progression, there's always a little blip at 3 months, which is associated with this measurement error. It could be real. It could be some disease process that started before they got into the study. But a lot of it is just the fact that some people were measured inappropriately, not inappropriately, but they were measured falsely low or falsely high. And you make a better measurement of them in the future, and it raises the mean.
So that's why you measure them twice, to try to get a more stable understanding.
Baseline, and that's why when we talk about progression, we also ask it to be confirmed 3 months later. So we want to say, have we made an error here? Let's see what happens in 3 months, and that will tell us whether or not they've truly progressed or not.
Now, you mentioned progression and confirming it 3 months later, but sometimes we've seen we don't just confirm it at 3 months, we confirm it at 6 months. How do we make that decision? Which is right?
I would say that they're both correct. The sustained progression is higher if you go 6 months. So something that's present at 3 months and then at 6 months, so you have a 3-month interval. You could have caught a relapse or that early progression at the start of an interval, and there might still be some residual that's actually going to improve beyond that. So you go out to 6 months to see if it did it improve or not. And we sort of think that 6 months is long enough. If it's going to improve, it's going to improve by there. So there's less reversion from that progression if you use a 6-month time period versus a 3-month. The problem with it, of course, is it extends the time of the study, which is the participants have to be involved in the study longer to get those subsequent measures. But it is a possibly better measure of what is true progression.
Well, Dr. Gary Cutter, as always, thank you so much for joining us. And I want to thank all of you back home for joining us with Real Time Neurology.